stay on track. Hey, Jill, Dana, can we, Megan? I'm sorry, classroom, we need to come to attention. All right. The next budget we want to hear from is the county clerk, and Cammie's going to do a small introduction of the 2 supplemental requests from the county clerk's office, and County Clerk Jamie Shu is here to answer any questions. Cammie, I'll turn it over to you.
Good morning. Am I on? Good morning. The county clerk budget shows no big changes. There are 2 supplemental requests, one in the elections division for an elections warehouse manager and technician, and one in the general county clerk's budget for an account clerk to staff citizen counter while providing need for support to the AP payroll and real estate. You can find these in your budget options under the county clerk. Let me get you a tab number. Tab number 4, you will notice that in the proposed budget, the account clerk 2 was included. There was no reason that one was included over the other, just simply that there was only room to include one. So if Jamie has a preference on one or the other, he'll let you know. And Jamie is here for any questions with your supplementals.
I would add that part of the reason why we included this position was as a part of the master planning work that we've done here at for the downtown courthouse and the law enforcement center. The addition of this position has always really been envisioned when those offices split. And so to me, this has been part of the plan as we've moved forward into managing how the clerk has to manage 2 different locations.
This isn't a question for Jamie so much as, and it's not really a question so much as a comment. But I was noticing as we look through the budget, and this isn't exclusive to the county clerk's office and some of these requests, but the salary for this particular position is quite low. So it does give me some concerns about turnover. But even more than that, the percentage that we're being asked to fund for benefits versus the salary. And we see the benefit request here is over $20,000 for a salary that's in the $30,000 range. And I am very supportive of the strong benefit package that we have as a county. I'm very concerned about how this increases our cost of employment and doesn't allow us to offer the kind of competitive salaries that we need to truly retain our employees. And that, as I said, is not specific to the county clerk, but is something that has come up in this budget again and again.
Yeah, absolutely. And I think that's part of why we're working hard to talk about our health plan and how we change that health plan so that we can have more dollars available to be able to pay people appropriately. We have a lot of folks who work really hard around here for not a lot of money. Capers, while at times it can be really expensive for folks that are at the lower end of the pay scale, is still, I believe, the 49th out of 50th best retirement systems for public employees. So it's a difficult challenge for us, for sure. And I think that's hard because I think a lot of, when we talk about the health plan, we tend to focus more on deductibles and co-pays and not this number. And I'm actually glad you pointed it out.
Jamie, you came all this way, so I want to ask you a question. So I think it makes a whole lot of sense. I appreciate having someone in that office downstairs when people come in, because they do seem to make a right or left-hand turn right inside the door if they're not paying taxes to ask questions. Can you give us sort of, I was sort of surprised to hear that you thought that person would still work for the county clerk's office, even though they're here. Can you give me some of the ideas about what their duties would be, as well as just sort of generally helping the public when they come in?
Well, when we looked at it, First of all, there's a couple main drivers for our counter. The first one is real estate, and the second one is elections are probably our biggest traffic. And then our third biggest traffic is where do I go? Where's my court? That type of stuff. So we're pulling elections out, but I think we're still going to get quite a few elections questions, voter registration, that type of stuff. In the master plan, there's a discussion of real estate moving maybe to a different location. So I think the number of visits to that counter are going to be not as intense. We'll still do boat permits because that's right next to tag. But to be honest, it's also a way for me to try to get help for AP and payroll. I did a statistic that when I started in 2004, we processed payroll for 375 people. We now process for 555 people. In the clerk staff, the last time we added a person was in 1994. And so it was a way, I don't think that there could be, to me, there wasn't justification just to have a person that would sit at the desk and answer questions if we're pulling most of those drivers. So it was a way to kind of double up tasks. Because AP and payroll are going to move downstairs. So when we move elections, the second floor clerk's office will move downstairs. So they'll be in that vicinity to provide that help to start with.
And then my second question was, if you can walk me through the math. I think I just wasn't smart enough to keep up on the maintenance person for elections. You have a halftime person now,
Correct.
right? Who is retiring or leaving?
Correct.
Is that right? And so the request, is that to make it a full-time position, or is that the request for, I mean, because there's the request is for 33. Is that to make it a full-time position, or is that now 1.5 positions?
Yeah, actually, if you read the supplemental numbers, to me, they're off.
Yeah.
Because it's making it full-time. So we already have budgeted 11,000. And then we hire temps to assist that person. So I would reduce my temp fund. So really what I felt was salary wise, I just needed to find $14,000 to make it full-time. But you also have the benefit part, which I think is a good thing to add in, which is for you to see that it's not just $14,000, there's benefits part of it. But by my calculations, we would need to add about 14,000. And Sarah and I have talked about it that, you know, I could also make some other cuts to cover that.
Okay, that explains why I was having, I just couldn't quite do the math there. That makes more sense.
Right.
In our book, we have both benefits and salary in there, so it may be off just a little bit. Yeah.
Right.
Make that adjustment on your tracking spreadsheet, Commissioner. So if we send you an updated spreadsheet, you can have that on that spreadsheet. That's it.
Okay, well, I would like to say this, which is, I want to give some credit to Commissioner Portillo. Commissioner Portillo was one of the first commissioners I've ever had call and ask about how core services are doing. And I will tell you that as the county has grown in departments and people, core services are starting to struggle a little bit. We have not grown them. And so I really appreciate it. The fact that my staff's been asking for these positions for a while, and I don't like adding to my budget. Sarah will agree with that. And it really was kind of Commissioner Portillo reaching out to say, you know, I see core services. And so I appreciate that. And I do encourage you that as you go through the budget to look at kind of how a lot of the changes are impacting our foundational services, human resources, AP, payroll, and so forth.
Thank you. I do think it's really important that we can continue to have the level of services that our community expects. So I appreciate you putting these requests forward.
Thank you.
I
And I
appreciate
think
you
we should
saying
pay
it
them
as-
all a little bit more.
Yeah, and I really appreciate you saying that too as well, Jamie. I don't think most folks understand how completely lean this operation works here. We're a very lean administrative team. I think sometimes we take pride in that, and maybe that's a bit to our own disadvantage because we don't, you know, I'm reluctant to add staff. It was really tough to see a position in this year's budget for administration. So I applaud the clerk for asking and appreciate all of our team and just what they continue to do with existing resources.
Okay, thank you.
Now we're well ahead of schedule.
The schedule. So I think as we get a few more of our behavioral health partners here, Bob can get ready and we can be ready to move into that pretty quickly. Or is there any other thing? Maybe we could take a bit of time. I don't know how quick, what your guys' schedule like is at noon. I would guess I want to see how you feel about tomorrow morning and come in. Do you want to come back in tomorrow morning just to kind of talk through some questions and concerns before we take the holiday weekend off to deliberate, or what are your thoughts? So if we've got a minute or two before that. Needs to be what we kind of.
I feel very confident with the conversation we had about the admin position. I think if we were to come back tomorrow morning, it would be more logistics of how we're going to walk through deliberations next week and what it's going to look like to kind of work with our spreadsheet, but maybe we could go over that now or as after we wrap up behavioral health. I don't know if there are kind of thoughts or questions there.
I'd also add that we are meeting with city staff this afternoon, and we may get some pieces of information to pass along to the commissioners as we move into deliberations. As I say that, we probably won't learn much of anything, but just because I jinxed it. But if we do, I could pass that piece along as well if we met kind of briefly tomorrow morning. But let's see what kind of time we have as we move through this. If there are questions, I know we have found a few little things here and there, as we always do with this process, in terms of the proposed budget that might impact just where we are on mill levy, certain things. I followed up with district court on their grant request. They did not build in the expense. So in the estimated budget. So I'd like a little bit of time, maybe tomorrow morning, to go through some of those things with you all. If I really appreciate coming in for, hopefully would not take the whole 3 hours.
Let's go ahead and just keep tomorrow morning then.
Okay, does that work? Unless we really feel like we get done quickly here and we can wrap it all up. So I'll try to, Cammie and I can try to build that list so we know what we're following up on, and then for that. So I know we are waiting on a few behavioral health partners. So for maybe want to take another 10-minute break would be great. Yes, commissioners, we're going to discuss our behavioral health community partners, and I'm going to turn it over to Bob Tryansky, who will provide an overview of, where do you want to start, Bob, with the spreadsheet, or do you want to start with your priorities?
Let's start with the spreadsheet.
Okay, I'm going to pull the spreadsheet up for Bob.
Okay, good morning, everyone, and good morning, commissioners. My task here is to try to take a number of moving parts in our behavioral health system of care and give you some context as to how they fit together in this year's set of budget recommendations and priorities. One thing I want to say from the beginning is that the Behavioral Health Leadership Coalition, meets monthly. All of our partners in that coalition have been a part of this process of identifying the priorities we're going to outline with you this morning, and some of the conversations that have led to some of the requests, both supplemental from each agency, and then some recommendations that have come from the county administrator as the budget has been put together. I think for some historical context, this is the 4th year working in the behavioral health space, with the county's sort of set of priorities. And this started in 2017's budget process when there was an effort to bring some behavioral health dollars, property tax dollars, into our system before Proposition 1 had passed. so that we could launch a couple of initiatives to get started on the work that we anticipated was going to go on for years. So when you look at this spreadsheet, there are two buckets of money, right? One is a set of property tax dollars and the other is a set of sales tax dollars. And so beginning in 2018, we started to access the property tax dollars, which at that time was an allocation of about $1.9 million to do a couple of things. Number one was to increase our psychiatry capacity in the community based on recommendations and from Bert Nash, from Heartland Community Health Center, and from a work group that we started to assemble called the Psychiatric Infrastructure Group. In 2017, we allocated about $900,000 with an aspirational goal to bring more psychiatrists to the community and support them with APRNs. So 2 psychiatrists, one at Bert Nash, one at Heartland Community Health Center, and APRNs at each place. There's an example of where we started. We started with a project that would embed behavioral health crisis clinicians in the emergency department with the aspiration to support that over time with peer support and to sort of like start to build the infrastructure in anticipation of a major staffing effort and workforce that would be required to bring a crisis center online. So how do we learn, integrate, and sort of start to track what are our volumes going to be like, those types of things. And then there was a significant amount of dollars to support the transitions supportive housing project, right? So our thinking was this property tax bucket of dollars ought to be dollars that could be put into initiating projects, experiments, pilots, so that we could learn what it would take to sustain them long-term when and if the sales tax dollars came online. Proposition 1, the first version of that failed. We went to Proposition 2, even though it was still called Proposition 1 on the ballot, and that brought the sales tax online. The sales tax was, we were be able to start accessing those funds in 2019, right? And so our hope here has always been to stand up, get started with initiatives on the property tax that would eventually move to the sales tax. So when you look at these initiatives, there are still some projects, right, that are on that property tax, and I'll walk you through those. And then there are some projects that are now envisioned to be sustained by the sales tax long-term. Any questions on that? I just wanted to give you that overview of here are kind of these two buckets of money, because at first it can be, or it can seem confusing.
And in addition to that, there's the community partner funding, which some of these folks receive funding for. So in essence, this is truly a third bucket in terms of some of our funding for the support. Does that make sense?
It does make sense. I think it's really interesting. I obviously appreciate that our community has stepped forward and voted to increase sales tax to fund this. But what we're really doing is piloting some of these things on property tax and then shifting them over to a sales tax, which is a much more regressive taxing system. And so we're really piloting with dollars that are less regressive, and then long-term funding with, excuse me, with more regressive dollars. And in a more ideal world, I would like to see other sources of funding for this. I recognize this is what our voters have asked for. This was also the only way that they were directly allowed to vote. So I think that long-term, we may want to consult with our community and think about less regressive ways to fund these.
Yeah, I think that's, yeah, I appreciate that.
I don't think we disagree.
Yeah.
So what I want to walk you through is the recommendations that are in the spreadsheet in the county administrator's budget proposal, as they fit within these 3 areas, right? These focus areas of both the community health plan and kind of the priorities of the Behavioral Health Leadership Coalition. So those 3 areas are prioritizing prevention, promoting integration across the system of care, and improving access to care. So I just want to walk you through this budget priorities sheet, which like as I said, we've had conversation ongoing for months with the behavioral health partners who are here. All of the partners in our coalition are here to answer questions specifically about these recommendations. So under prevention, can we pull that document up? Yeah, thanks. Okay, but you do have it in front of you, right? Yeah, so let's talk about prioritizing prevention, because as we said, this needs to be the priority, and that's why we put it first. Although if you look at it at this point, the allocation within what we're doing is kind of the smallest of the focus area allocations. So one way to judge whether we're making progress or not, and Lori Alvarado and Dan Partridge, who are kind of the executive champions of that realm and coordinating these projects, have said, if we're making progress, when we look at ourselves 3-5 years from now, we should have more investment in prevention, right? And maybe less investment in crisis services. So under prioritizing prevention, we want to continue to support the strategic planning process, the SPIF process, data sharing and analysis, and projects that address substance use and suicide prevention countywide. Let's break that down. When we started this, we allocated $177,000 to DECA to lead the SPIF process and to start to make recommendations after building a coalition, Engage Douglas County, of broad coalition of stakeholders. How should we allocate these dollars? So at this point, we're recommending that in 2022, we actually allocate slightly less money to DECA, $150,000 instead of $177,000. And what we would do is continue to support Engage Douglas County's initiatives. So those include the Douglas County Youth Prevention Board, the Douglas County Behavioral Health Summit, good behavior game pilots in Douglas County Elementary, pre-K and community youth program settings. We've talked about all of these in study sessions with you. The sources of strength pilots in Douglas County secondary schools. We have a goal to implement sources of strength in 5 schools over the next year. The Handle with Care partnership, we're hoping that project would expand beyond Baldwin into Lawrence and Eudora, and the Engage County Coalition partners continue to advocate for that, talk with our school districts as well as our law enforcement partners. And then the implementation of the federal drug-free communities grant. So DECA took the initiative and the leadership to seek a federal grant so that we would have more capacity to do prevention work in Douglas County. And in the second year, they were successful at that. So those dollars came online in 2021, will continue. And the responsibility of the county in partnering with DECA on that grant is to match the funds, right? So they've got $125,000 coming in on that grant, and then we're matching that at $125,000, plus they have the additional capacity to continue those projects. All right. One of the components of Proposition 1 was to bring My Strength online and to provide My Strength to all Douglas County residents for free. So the cost of that will be $28,500 in 2022. We are working on and have been working on now for 2 years the process of developing and implementing a comprehensive plan to address suicide risk in Douglas County. We have a lot more data, but just in a nutshell, the suicide mortality rate in the state of Kansas has increased by 42% over the last 20 years. In Douglas County, it's increased by over 80%. So we have an issue to be addressed. We have too many people in our communities who are at risk. And some of those individuals, in fact, the majority of those individuals don't have an underlying mental illness. So there's just a lot of work that we need to do in suicide, reducing suicide risk and in suicide prevention. Headquarters and the health department have been really instrumental in leading this work. Public health on the data and analysis and reporting side of the equation, and then headquarters with the implementation of zero suicide. So when we started and made zero suicide a priority, roughly $150,000 were involved in getting that educational effort, the organizational self-studies, workforce studies in each of the agencies that have participated in zero suicide. But because of COVID, the cost of that work has kind of been spread out and stretched out. And so in 2022, we are going to need additional dollars to finish that work as originally proposed. So in this case, the recommendation is to reduce DECA's funding to $150,000 and then to put the additional capacity there so that headquarters can continue to lead that work. Do you have questions? And then we want to continue to support tobacco cessation and anti-vaping initiatives. The does not really have a lot of dollars invested in that, but our partners do. And when we look at the data, we've made significant progress on being ahead of the state in terms of our vaping statistics and data, and the tobacco cessation work that's been done for years, led by the health department and our partners, really shows that investing in prevention works, right? What questions do you have about just this overview? Okay, let's turn to promoting integration across the system of care. In 2022, the investment in the treatment and recovery campus will primarily be an investment with behavioral health partners, a new entity that is formed partnership between Burt Nash and LMH Health to provide operation and sort of navigation and leadership for running the Crisis and Recovery Center. There's a big placeholder in this budget of $2.8 million to support the gap between revenue and expense that it's going to cost to operate this crisis center. And we have work to do still to tease out what the funding model is going to be. We've been working on this for 2-3 years, right? And we're close to being able to come to you, but it makes sense right now to say what we said to the voters, which is we anticipate that it will cost at least $2.8 million to run the crisis center. So we're holding a placeholder in the budget for that. The data sharing collaborative, which work being led by LDC Public Health. There is an effort, a project to build a data repository in partnership with KU. LDC Public Health is leading that effort. This $30,000 on the sales tax was something that was funded last year. And I just wanted to show that we're continuing to fund that on the sales tax. The integrated crisis team, the team that's been working at Burt Nash, the team that's been working in the emergency department in partnership, DECA has a piece of the work that's been happening in the emergency department. Burt Nash has a piece of the work. LMH has, employed the director of that crisis team. And what was always envisioned was that team, that workforce will kind of be the core, the starting point of the workforce and the staffing that we need in the crisis center. So there have been times where that, was originally proposed as a $400,000 act-like pilot in the emergency department. We got to over 2 years, kind of the base funding has been $250,000. We came to you in the summer and the commission approved funding that would take that up to $466,000 this year in 2021. We anticipate that some of those dollars will not be spent in 2021, but we will need to continue to support that staffing that will flex between the emergency department and the crisis center as the crisis center comes online. So we're back to a recommendation that we believe the cost of that, a good budget figure, is $250,000 on the sales tax. The Douglas County Peer Fellows Program is in its 3rd year. I would say that we've had good success to the degree that it was possible to have success given the disruption that we experienced during COVID. So we are suggesting to keep the funding flat for that program, but continue to build relationships with additional partners so that those peers will be in multiple sites in the community. So we started this program exclusively with Burt Nash. Last year, we now have partnership with the Lawrence Douglas County Public Library. We have peer fellows both on the Heartland RADAC Care Coordination Team and also working in the emergency department and at the Housing Authority. So the program works. It hasn't moved as quickly as possible. We've had a lot of disruption with that program, so we just want to sort of maintain stable funding and continue the path set out for that. A major area I think we need to look at is the supportive housing area. We are going to need to continue to find ways to increase the number of units, both transitional and permanent supportive housing units. So recommendation is to convene a behavioral health supportive housing work group in 2021. And here are the kind of priorities. So we want to continue to provide operational support for transitions. We've always talked about that at a level of about $180,000. We want to continue to support Artists Helping the Homeless, Kairos House Transitional Housing Project. And in 2022, we would like to continue to support Artists Helping the Homeless at the same funding level that we have for the last 3 years. However, Artists Helping the Homeless has opportunity to expand the scope of that project because what started as an anticipation that we would serve 8 to 12 people at Kairos House is not possible for a variety of reasons. So Artists Helping the Homeless is very nimble, very flexible, very responsive to what the needs are as they emerge. And we'll talk about this with Artists Helping the Homeless. We want to maintain that funding level in 2022 with the expectation that they will serve more people than originally anticipated with another facility. So kind of a growth in scope with a sort of stable funding. We want to continue to support clients in transitions in the cottages, working together, both with Burt Nash and with the Housing Authority and with Heartland Radak's Care Coordination team. We want to explore capital support for a supportive housing project at DECA's Lakeview campus. So transitional, supportive, sober living housing for families and children at DECA, its Lakeview campus. We've talked about this for 4 years, and we anticipate that project would start in 2023. And then, the integrated 24/7 988 crisis line and expanded mobile response. We're at a point now where I think we have project models, proposals, and we've always anticipated that the cost of that would be to get it started somewhere around $750,000, and we're in that frame. If we were to get approval on this for the 2022 budget, then we feel pretty confident that we could get started with dollars that were budgeted in 2021 for this work. On the psychiatric infrastructure allocation, we're recommending a slight increase in funding from $500,000 to $600,000. And that's to support 2 kind of new components that we feel that we need to support as we bring the crisis center online. One is half an FTE for a full-time medical director. When we started this work, we did not anticipate that the project would have a full-time medical director, but given the level of care we want to offer in the crisis center and the medical component of this work, our partners, Behavioral Health Partners, LLC, and the Psychiatric Infrastructure Group strongly urge that we have a full-time medical director, at least for the first several years. So, and it's important to know that when we started this psych infrastructure supplemental project, one of the hopes, and it still is a hope, is that we could eventually leverage the reimbursement capacity of our federally qualified health center at Heartland, but we had kind of a setback with a candidate in 2021 who we anticipated was coming on board, and at the last minute they actually pulled out of the contract. So we want to divert, or we want to sort of direct those funds towards this half FTE of psychiatry in 2022. And then, as we said 2 weeks ago, we have this opportunity to stand up the psychiatric resident rotation, partnership between Burt Nash and KU Med. This is in the budget. Our hope and anticipation is we will find a permanent funding source, but we need some time to explore that and to work out with the funding source. We have some tangible suggestions and ideas there. So, and then to continue to support the gap between revenue and expense for the 3 psychiatry positions at Burt Nash, up to 40% of the overall cost not to exceed $320,000, which stays flat and stable. On SUD programs, we want to continue to support the Regional Social Detox Access Project and embedded peer support in the LMH Emergency Department for 6 months in 2022. So we will not be ready to offer detox in the crisis center until the middle of 2022. And so we want to support this at 6 months. Continue to provide supplemental funds to reduce disparities and support SUD treatment for men. We're suggesting an increase to $112,000, $112,500. I think I'm off by $3,000 on my last line item here on this handout, but what you have in the budget frame is correct. Let's talk about care coordination and barrier reduction, because I anticipate that this will be an area that there will be more questions on given our conversations with the criminal justice services conversation. So within behavioral health projects, This service in the community when we started was intended to build the capacity that Heartland Radac had to serve clients with comorbidity. 25% of a grant from the state was dedicated to Douglas County. When we started working with Heartland Radac, in the conversations with Heartland Radac, I said, tell me a little bit more about this to Jason Hess. And he said, well, we've only had like 9 referrals in the last 2 years. So there's this capacity on ICM that we were not leveraging. And as we talked about that, I thought, is there a way that we could expand that? So not to an intensive case management service, but could we respond to what we were hearing during the Proposition 1 process, which was we don't need more case management necessarily. We need navigational support, and that navigational support needs to go in a system spanning way. So we brought the care coordination service online in 2018 with 1 care coordinator. We expanded to 2 in 2019. We expanded to 3 in 2020 and have intended to go to 4 starting in 2021. I think what's important to know is that in each of those years, the number of referrals to this service have gone from, I think in year 1, we were at about 400. We were at 500 in year 2, 700 last year. And if you look at the preliminary data, we're going to probably have between 9 and 1,200 referrals in the course of the year. So this team needs to be larger. It needed to be larger last year. And that's why the request is in this budget for the 5th FTE for care coordinator. Now you also have a request, as we talked about on Monday, for a 6th care coordinator that would be dedicated to criminal justice services. And so, as we look at this in a system spanning way, it would be a care coordination team of 6 FTE. And when you have a team of 6 FTE, we need some additional supervision, coordination, and leadership. So on the sales tax part of the budget, we're recommending one of those 2 FTEs plus the 0.5 supervision. And when this request came in from Heartland Radac, it was also to add a recovery coach to this team. And between that time and our follow-up conversations, we've reduced that request from $223,000 because we're going to leverage the peer fellows capacity in 2022 to provide that recovery coach and sustain that recovery coach through that program with the individuals that are in that peer fellows role, now. So does it say 223 in the? Yeah, so it's 183
Yes.
is.
Yeah, and we'll correct that on your budget options sheet. And then I believe the commissioners, I forwarded information to you earlier today from Stacy Cooper with Heartland Radac about the CJS embedded Heartland Radac court care coordinator for your information.
And I will say, I haven't had a chance to read what you forwarded this morning. But can you help clarify, Bob, is that 6th CJS associated role a clinical role, or is it another care navigator role?
It's a care navigator role. And I'll let Stacy Cooper, who's here from Heartland Radac, kind of talk through that because I think it's the type of thing that if the concern here at the commission level is that it should be a clinical role, then we can look at how we get there.
No, my concern is that we're being asked to do 2 different things. Like I think that our probation officers should be helping to connect their clients to care. And so rather than having an external care navigator, our probation officers should be trained and capable of doing that work. The argument that was put forward when we were discussing the criminal justice services budget is that there are times when our clients can't be connected to care because they don't have a diagnosis. And a quicker diagnosis would help connect them to care. And if this role is a clinically licensed individual, they could do that diagnosis on the spot and connect to care. So if it isn't a clinical role, I don't see why this isn't work that could be done in-house.
And I don't disagree on the surface. What I would say in additional conversations is, again, remember I said, I think we need to think about this as a team of 6, and some of those care coordinators are licensed clinicians. And so both that capacity and the capacity that we have, DECA does a lot of this work as well. So if this team does their role well, then you're going to have that option from this team and the members of that team. And that capacity continues to walk with the person when they're in the community and they separate from the probation officer. Like I said, I would rather have Pam and Stacy kind of talk
Okay.
on the details of this. And it may be a conversation.
Yeah, I'm just struggling why we can't have our entire probation office then work more closely with a team that's already established, why we would need someone embedded. Because I think that that then implies that our probation officer shouldn't be doing this work. And I think that that's the wrong message to send to our community corrections folks.
Okay. Can I,
Yeah, Pam and Stacy, we can just discuss this a little bit more detail.
Thanks for the opportunity to just discuss this in detail. The value of having this embedded care coordinator, it basically, we have an infrastructure and relationships of care coordinators that are already existing in the community. And so some of these relationships we build over time allow us to navigate in a very simple way to walk those individuals and clients indoors. And so by having us embedded there, that is also going to be able to take the burden off the criminal justice side and allow us who have been doing this for quite some time to navigate. It takes a lot to ensure that folks are not only properly diagnosed, but get through the right doors, whether it's Burton Ash or Heartland Community Health Center. And these individuals are incredibly complex. So oftentimes there's this comorbidity going around. And then they have their kids in DCF custody and they're Indigenous. And there's so many different components here. And so given the fact that we've been doing this for this county for so long, we easily navigate these complex issues. And I see the point and I reflect on that to say, we definitely want to be in partnership with these probation officers and court service officers and diversion officers, et cetera. But sometimes you have to kind of leverage the expertise of clinical staff. And so what we're asking to do here is to add to that team to ensure clinical supervision, the clinical components, because sometimes we're going to have individuals on the team that are licensed. And a lot of them are licensed from a substance abuse lens. But depending on the funding source, like for example, if somebody has Blue Cross Blue Shield, I don't have to have a licensed staff call Valley Hope and Atchison to walk that client in the door there. But in order to walk into DECA, I need an assessment that's done by a licensed staff. These are so many different ups and downs and different avenues about how to get a resource for one person. And frankly, I think that we're the experts at the table to be able to do that seamlessly. In addition to the fact that these individuals will not be on probation, we hope, for a long time. We want them to get connected to services. We want them to get supported. We want them to be on meds if that is what a doctor recommends, but we also want to follow them into the community. And so by embedding us in this, realm, that allows us to start with someone and to connect them and stay connected to them when they exit their legal requirements. So we see some of these valuable points to the role we're playing in the system already. I hope that gives a little bit more clarity. Does it?
Pam, did you want to speak to the supervision and the probation officer piece of that question?
Again, oh, sorry. The staff, we do extensive training on services and things that are available in the community, but officers are spread pretty thin. And generally the crisis people come to the top oftentimes in terms of attention. We just feel like if we had more expertise in-house, we could try and get these people to care sooner versus waiting for them to get to a crisis point. We staff pretty regularly in terms of the clients that we're serving and what we think we need to do, but would help to have some professional expertise to kind of help direct us so we're not expending resources unnecessarily. I know the officers that work for me and work for you, we do a lot of, it's pretty extensive, it's pretty involved. There's a lot of documentation and a lot of risk assessments and various things that we have to jump through a lot of hoops to make sure things are done according to standards. And sometimes we just want to make sure we're not ignoring the client need in that process. Sometimes that can be kind of overwhelming and complex.
Yeah, and I think that my big concern is that if our argument is that we're spreading our current community corrections folks too thin to develop this level of expertise, that if we outsource it or even embed it, what we're doing is saying that this isn't part of the role of community corrections to kind of develop this expertise and to help navigate into the community. And instead, we're saying it's an external component. And I think that that's then kind of continuing that lack of capacity within our current office. And so if the real issue is that our officers don't have the capacity to do this level of work, then we need more officers to spread that work around. Or we need more training to bring that expertise in-house. Because if we continue to kind of embed and outsource, then I'm worried that we won't see this as the work of community corrections to do that really solid handoff to the experts in our community once folks are out of our care and our supervision.
Well, I think that that's still going to be our role. There's no way that this care coordinator is going to serve the 250 clients we're currently supervising. So, we're only going to elevate those folks that we feel are struggling, that we're just, for whatever reason, not figuring out what the need is and getting them connected the way we need to. The other thing was thinking that it also could help serve the other components of my department. There are a number of clients that we have that are struggling, that are in crisis. Then we got to figure out in a more expeditious manner how to get them connected. Staff are working diligently to get folks connected, but we're supervising probably well over 500 people as a department, and it's just a lot for everybody. But everybody, I don't want to underestimate the staff are doing this work already. It's just that we feel like we could use a little more assistance getting folks connected and having a professional that we can consult on. Is this the right direction for these folks?
I think I really appreciate the perspective, Commissioner Portillo. I think, and I appreciate your advocacy for staff, and that, making sure that our staffing levels are appropriate to manage the function. And I think that's something that, I think Pam, I think it's something we can just continue to reflect upon as we try to just further enhance and refine the work that we're doing on alternatives to incarceration and in CGS programming. And let's just keep talking about it and see how it evolves through that process. I think, but we wanted you to understand, I think staff's intent was, hey, this is a great program. Let's create a seamless transition from incarcerated to, or justice involved to non-justice involved. That team can really help us do that piece. Generally, the work of a correctional, a probation officer stops when they're no longer justice involved. And so it's just a different approach. And I think it's something we can continue to modify.
And I think we want to see that, especially with the specialty court clients it's pretty intensive. And then suddenly you drop out. And then where does that support system come from?
Well, and I really appreciate that. And this is, I think the experts in our community are doing a fantastic job. And I want to be clear on that. I do think that part of, as we have our specialty courts, part of someone progressing through specialty court is kind of that disengagement with the criminal justice system and engagement with community-based supports. And that's something that we guide them through as they work their way through our specialty courts. And so that handoff should be a warm handoff. At the end, at graduation, those supports should already be built up. It shouldn't just be a dropped, you're no longer on supervision, whether they're going through a specialty program or not. I think we have to think about what is the role of that warm handoff. That's where I think we need to be. I have concerns about kind of what does that look like within our community.
Yeah, I think, and it can be difficult to get engagement when you don't have the court behind that person. It's sometimes hard to keep people engaged in service. And we are working on trying to make sure we do that warm handoff, but we can't make the client participate, obviously.
And when they do, then what happens if their health declines? Because we have people who have graduated from behavioral health court, and maybe they choose not to go back to the community health center because their experience or their perception of that was part of the supervised piece. Well, who helps them to navigate over to the community health center, which might be a good alternative? Or if there are ongoing substance abuse issues, who makes sure that that person continues to be connected to DECA, if they have a trusted care coordinator as part of their experience, right, who is not part of the criminal justice piece of this, is it likely that we will not have somebody disengaged as we see they have and they do when
So couldn't the same argument be made that then we should be helping them connect with community resources as they're kind of transitioning away? I mean, it's not a hard, they're
Yeah.
in BHC and seeing us every week and then nothing. I mean, part
Right.
of the specialty courts is kind of stepping down from the amount of supervision. And so it should be stepping down from the amount of supervision and being connected with those community pieces. So I actually worry that then we're bringing in the community piece into the supervision and you have that negative association from the very beginning, because now we have someone embedded. So it's always the community piece is being connected to supervision and justice involvement rather than that handoff.
Yeah,
now
I
you're-
think one of the
you're outside of
language
it.
things and concepts that we are trying to promote also as this evolves is it's not just a handoff. It's a walk with. So a person with a chronic mental illness, right? Schizophrenia, bipolar disorder, that was one of the underlying factors that had them wind up in jail or the criminal justice system. They are going to need somebody to walk with them. You know, a crisis is a moment in time. Recovery is a lifelong journey. And some of the individuals that will be able to independently and should be independently go through that recovery journey. Other individuals will need ongoing support, in some cases for the rest of their life. So, I mean, this is a big conversation. So,
Yeah, and
Yeah.
I do want to speak to that last comment that you made, just to kind of give some clarity to it, this informed consent concept and confidentiality, and how we keep using this language embeddedness because we want to be a part of the communication flow of these probation officers and those legal system individuals to be able to advocate, support, educate. But our work is bridging these folks into the community resources that exist, like walking them into a 12-step meeting, walking them into Burt Nash and meeting them there. So while we are incredibly embedded, which would enhance our communication efforts, we don't want to solely meet with these individuals while they're in-house, because we don't want to give the impression that we are connected or that we could, impact their probation in any way. Releases information and confidentiality and informed consent is part of this work. And we want to ultimately leverage these individuals' relationships to create motivation for their own internal change. And that happens outside of, the criminal justice dynamic. And so our goal really will be to start with those individuals in the community, but we're going to be getting those individuals from the referral sources within the criminal justice realm. And I think that, kind of also speaking to what Pam said earlier, there's so many individuals that are being served by these probation officers. I kind of see the role that this care coordination can play are the more complex, more like there's this buzzword that we're talking about, the high utilizers, the individuals that have multiple police contacts in one day. They're accessing the emergency department. They're not maintaining stability for whatever their substance use or mental health diagnosis are. So something that, the run-of-the-mill individual that generally is successful in this setting probably isn't going to be our target individual. I would imagine that these are the ones that have incredibly complex systematic, barriers that need maybe some outsourcing to support. That helps.
so if we could turn back to just a summary, right? And then open for questions. In terms of new spending, Crisis and Recovery Center, a placeholder for $2.8 million. The 988 Crisis Call Center and Mobile Access Team pilot, not to exceed $750,000. Intensive Care Coordination, adding the care coordinator, the half FTE of supervision, building on the recovery coach capacity that we've leveraged from the Peer Fellows Program, $180,000 on property tax. Integrated Crisis Team, continuing that funding at $250,000 on the sales tax so we can achieve those objectives that we've outlined. But we cross over from 2021 to 2022 as we implement that. And then the last piece is the SUD treatment for men, expanding that by, I think the number is $35,700. or $37,500, but that's my typo there, and I apologize. I apologize for that. Questions on the summary of this, and then we can turn into specific questions with the partners and their supplementals.
Well, if we don't have any specific questions on that, we can review. So what always gets sort of complicated with behavioral health partners is sometimes we have supplementals that aren't necessarily reflective of their behavioral health priorities or in total in terms of some other asks. So we can review those if you want, if you're ready, if you want more of a rundown of each of them, or you can just simply let us know which ones you have questions about. And I do want to spend some time talking through the homeless response request from Bert Nash, just so you guys can understand that process.
This isn't really, it's more just a statement, in that I just want to tell Bob, which I appreciate, this has been a long ongoing work with the Behavioral Health Leadership Coalition. And I really appreciate the partners' work and your work in kind of bringing us a package of these are the priority activities that we're trying to do. And this is our recommendation as a Behavioral Health Leadership Coalition. I know, partners, that must have been hard to decide how to do that, but I really appreciate the work that you did prior to this meeting to sort of identify those strategies and where each one of those dollars come from. When we were talking about human services earlier, this is what I'm hoping we get to in human services. I don't think we'll get there quite yet, but it's that same sort of strategy. I really appreciate the thoughtfulness around how all the partners work together to provide a continuum of services for behavioral health. So I appreciate that. Thank you.
Well, and I think I'll speak for our group of partners as well. We appreciate the types of questions and the ways in which this coalition is being pushed to sort of provide the data that everyone needs, right? And to provide the integrated thinking that everyone needs, and to do the learning that we need to do as we evolve into an integrated system of care, right? There's multiple parts of this. You can start by communicating as partners. You can start as cooperating, collaborating. Integration is hard and complex. And this is the phase we're really moving into with this coalition. And it's exciting that we're at this point, because I think we're ready to absorb the heat that it's going to take to make these decisions. So to have, we've always had engagement from the commissioners directly in the Behavioral Health Leadership Coalition. And then I know that you all have taken initiative to ask more questions and really sort of understand how the moving parts work as we go. So it's a real symbiotic relationship. And I think that's why we're making the progress we are. So thank you.
We're trying to get to the bottom of Ben's SUD. Sorry.
It's okay. I had some specific questions about Bert Nash. I don't know if we're moving to,
Yep.
is that,
Stephen O'Neill and Patrick Schmitz are here
As
from
well
Bert
as Mark
Nash.
Shiggs. Yep.
and I do think it's important for us to point out that Bert Nash is a really unique part of this overall coalition and a really unique external ask for us, because we do have that very substantial funding piece of benefits for Bert Nash and the health insurance piece, which takes up a big part of our overall discussions here. One piece for all of our external partners that I really appreciated in our budget documents was that discussion around equity and how the work of equity is a part of the organization and what the organization has done from an equity focus. I think that this part of the discussion in your materials, I was a little bit wanting for more information here. And a big piece of it was kind of that focus around paying compensation, which is hugely important. And I do appreciate kind of that focus on getting the compensation of folks up. But Bert Nash is our community mental health center, and we're currently in a year of incredible social unrest where we're dealing with big questions around how systemic racism has shaped many institutions within our community, and we know that many community members are struggling with some of the results of that. And I didn't see the word race show up anywhere in your discussion of equity within these documents. So can you just help me understand a little bit more what Bert Nash is doing to make sure that all of the staff are educated around issues of systemic racism and how we think about diversity, equity, and inclusion within our work, and how that kind of fits into a lot of the work that you're doing in collaboration within the community?
Right, so I'll let you jump in, but Bert Nash has for years had a diversity committee made up of our staff who lead our efforts to educate their fellow team members around the issues of diversity, regardless of what, there we go. I can definitely hear it better now. So I'll start over. Bert Nash has for years had a diversity committee made up of staff who have for years worked on issues of diversity, equity, inclusion before we were even really talking about it significantly in our community and across the nation. We have continued that work on a more significant level last year when we brought in a trainer to help have the conversations, raise awareness. That's what we used our annual funding, annual training fund for that. And we have also just recently contracted with another consultant around issues of diversity, equity, inclusion, that she will be walking our team through conversations about that, the difficult conversations. So we are actively working in that area in terms of equity and salary and pay. I'll actually let Stephen jump into that because that's something he's extremely passionate about. And we actually had a pretty a lively conversation about that this morning right before coming here. So.
Yeah, so one of the other things we're doing right now is we're going through the national CARF accreditation process, and CARF is one of the major national accrediting bodies for the work we do. Diversity, equity, and inclusion is a key element of that process. At the same time, we're going through that, we're going through our strategic planning process. As a component of our strategic plan and our CARF accreditation process, we will have a standalone integrated and standalone diversity, equity, and inclusion plan as part of that. So I imagine you will see the word race throughout our strategic plan. We've been having difficult conversations as an organization. I know at the highest levels of our organization, Patrick and I are both white men, and the last 18 months has provided significant opportunity for us to reflect on who we are as individuals and really our entire life experience. And we've been able to have some of those discussions with our staff. The reason we asked for help is because we need help. And that's why we brought in Anthony Butler last summer. And we've contracted with Danica Moore, who's going to be working with our whole organization to help us have some of these critical conversations. Candidly, we felt without that external support, we may do more harm than good. And that's the feedback we got when we did ask for help. So I know we would be eager to share our strategic plan, our diversity, equity, and inclusion plan. We did talk a lot about pay because I think we view pay as a key equity issue and as something that is really significantly impacting our staff. And I think as an organization and working in a field that employs significantly more women than men and individuals of color, I think that the inequities are like amplified and compounded because you're laying racial and gender inequities on top of what I consider to be really unacceptable inequities in terms of how we value labor across sectors. So I don't know if that answers your question, but I assure you we're working really hard as individuals and as an organization, but I know we have significant more work to do in that regard.
Thank you. And I do look forward to seeing the diversity, equity, inclusion strategic plan as part of your overall strategic plan. Thanks.
I have some questions about, as you think about pay, the county, and Commissioner Portillo brought this up earlier, Burton Ash is one of the few entities that we provide health benefits for. Has there been any consideration of increasing your pay by changing the health benefit structure? So detaching from Douglas County as an entity. I think you have a larger human resources department than the county does. So it would seem like it may be good for you to determine whether, there's an ask in here to increase salaries from the county, and we also have an increase in our healthcare costs. Have you put any thought into that? Has that been something you've talked about?
Sarah and I have had that conversation off and on for the last couple of years, and I'll be very transparent. It's a double-edged sword for us, right? It's a great benefit, but it does come at a cost, and attachments to that. The other thing is, I will just say, I actually, Stephen and I talked about this last week. We think we do need to start looking as a way of helping the county as well as helping ourselves. How quickly we can do that, and how we can manage that, we won't know until we have a chance to look at those numbers and what that might take. But we actually are starting to look at that, Patrick. And so I thank you for that question.
I would just like to add, and consistent with my earlier comments on compensation, the world is not lacking for nonprofit organizations with $900 a month high deductible health plans. So I have no doubt that we could go to market and acquire a significantly cheaper health plan. But our employees will notice that. They will comment on it, and there will be consequences to that. Because I myself have been working at an organization where we transitioned out of desperation from traditional PPO plans to high deductible plans paired with a health savings account, which is what you would see at other mental health centers. So again, we're actually in the process of evaluating other plans, but when we do talk about that, you will have 230 plus Douglas County citizens who get really, really good health insurance at Burton Ash, who will have thoughts and feelings about that. That being said, I do think there's a lot of opportunity. I've just been on the receiving end of what's happening in my sector as it relates to health insurance over time.
And related to the conversations with Sarah, and I know there was transitions on your side, our side, in terms of HR staff, but we have offered to work with and collaborate on looking at variations of the current system. And so, this has been a conversation since I came here 4 years ago about that and how to move that forward in a different way. So.
Yeah, and I appreciate that it's taken 4 years, and since I've been on the commission 2.5 years, and I know that we got thrown a lot of curveballs, but I do think it's something that, Stephen, you're exactly right. It is a pressure point, and it is a pressure point in our budget. And if we transferred it, it would become a pressure point in your budget. And I think that it's something to continually look at. I want to make sure. It looks like Commissioner Portillo was going to jump in. I have a different question as well.
Oh, no, it was just this is my first budget cycle as a commissioner. And so it's something that it sounds like there have been long conversations about, even preceding Commissioner Kelly being on the commission. So I guess I'm just a little kind of confused of what do we need to get to the point where we have clear numbers from, Patrick, you mentioned that you don't quite know what it would take to transition. You don't have those clear numbers. How do we make sure that this is the last year that we don't have those numbers at least?
But one thing I can say in that conversation is the county is looking to change its model. So, our plan is for the 2022, 2023 health plan year, we will be moving to a high deductible plan for all county employees. So in some ways, that's going to happen already, because that's the direction that the commission has told us to move into in terms of development of our plan. Our deductibles have already increased pretty substantially, so we're moving to that park already. So we're going to continue that work on the county side. I think the question becomes, if Burt Nash was able to find their own plan, that, what would the cost subsidy of that be? What would be the expectations of that, and how would we approach that work? That part I'll let Patrick.
No, you're right. And like I said, there was those transitions. So you had to kind of wait a little bit before you could start looking at some of those things. Stephen just talked to our HR last week or Monday of this week and said, let's start contacting some agents and start seeing what it would take for us to get some idea there. So I imagine it's going to take at least a couple months to get through that process, and then lots of conversations about timing of it once we find out what those numbers look like, and if they scare us away or say, hey, this looks really possible, what do we do next?
Yeah, and I candidly don't know that we've ever been asked to go shop for another plan. So I hear that very clearly. And again, we're working on that for a variety of reasons. I mean, I think it's growth limiting for Burt Nash. We've become a very assertive, growth-oriented mental health center, and I don't want the liability of the health plan holding us back from accomplishing our core objectives, things that we believe are critical for us. So I think the time is really good to look at that. I do think when we look at shifting that liability, we have to do it in the context of the impact that that would have on all these other funding changes you're approving. Because if we just pull out the current county funding for the liability plan, you're going to have to see, with nothing, you will see a very different mental health center, because we will have to start rationing care. We will have to start operating a little bit differently. So I think these will be really good, critical conversations for us to have and to have together, so that we can make what is the best decision. But I anticipate we will have numbers here in the next several months, so we could come back and have a conversation and evaluate a couple of plans.
Thanks. I think that is kind of part of a broader conversation around what is the relationship between the county and our community mental health center, because we're seeing this as kind of what is the integration and what is the separation. And that's a big part of that overall conversation when it comes to funding and compensation and HR and all of those pieces. And so when we think about that kind of administrative infrastructure of our community, this is a big part of those ongoing conversations.
Yeah, I have two more questions, and one is going to be about the homeless, so it may give us a chance. So I'll ask the first one about the sliding scale and your request there. You mentioned that was due to COVID-19. Did you put any thought into an ARPA request for those dollars? Is that there, or was it all in relation to COVID-19? Can you talk a little bit more about that, the change in the sliding scale and the increased cost of the sliding scale?
With this, so historically, we run out of our sliding fee scale money like long before the year is over. Typically, it's September and October. We don't ever turn services off. Burt Nash does not ration care. We don't limit service in any way, shape, or form. We don't even take people to collections currently when they don't pay. So I would say our request on the sliding scale is not entirely COVID related, because we dramatically changed both our fee scale and our sliding fee scale to make our services more accessible to the community. For example, prior to the change, our lowest price point for outpatient therapy was $60 an hour. Good therapy typically happens in high intensity early on, like a week, like every week. So if you you could make a lot of money and $60 a week would still feel significant. So we changed our sliding fee scale to make that entry price point $10 and $5 for group interventions. So in some ways, we're like, we made services a lot more accessible to people. So they want to come back, and the drawdown, that difference between what we charge the patient and our fee is greater, because instead of $60, it's 10. So you see that playing out as well as just a broader increased need for services generally, both in terms of how often people want them, but the intensity and complexity of the problems that people are bringing in. Mike, do you want to chime in on that as well?
Thank you. The COVID definitely has increased the demand for services, especially sliding scale. But that's only one piece. And obviously there's been other funds available through the COVID funding for that. So the ongoing gap is the fact that we're just spending more money than what we're receiving for that. And a good example, like Stephen was saying, with let's say you have $100 service, whether that's the cost of the service or the fee. If our sliding scale is $60, then the county, in essence, is paying for that $40 gap that we're saving that client. But we're seeing that with the volume, that $40 is getting used and exceeding what we're getting from the county currently. The other $60, let's say, is the sliding scale amount that we receive from the client. Our collection rate right now is about 25% of that. So out of that $60, we're maybe collecting $15 from the client. And so that is another piece that, obviously the funding we get from, say, the health insurance, things like that, those help us to offset those collection costs, and not collection costs, but the actual collections where we're not able to collect from the client. So obviously it's a complex funding model, but that's part of it.
I'd like to add a little bit. I think there is some complexity in this piece, charitable care. The county pays for finances charitable care in some places, but most of our community health partner agreements are not necessarily centered around charitable care. We landed on this for what I affectionately call good people money to support charitable care in this situation. I think this gets back to some of the partnership issues. I don't disagree with anything Stephen said in terms of reducing the sliding fee scale, but if the notion is the county is supposed to make up the gap, we were not consulted as a part of that process. So I think that's part of the conversation we need to have in terms of how the funds are used. And is that really the priority for the county in terms of, meeting that gap for sliding fee scale services? I think, I don't disagree with anything anybody said in terms of how to approach the care and where we go from there. And I think certainly there could be some ARPA funds that could be used to sort of meet that gap. But this kind of issue of relationship relates to the other requests that we see here from Burt Nash in terms of cost of living increases for programs that we specifically fund, including RAP and Peer Fellows. As a general rule, the county doesn't pay for cost of living adjustments for folks outside of county employees. And I get lots of requests for those every year. And in most cases, they're not recommended in the county budget. And I do worry, because we have such a tight partnership here on some of these services. How does that relate into making sure that services are provided to the community in a fair and equitable manner?
To your question on ARPA funds, there is no clarity yet on those. So there's no ability to really request those and how they could be used. So.
Yeah, we may have to. Go ahead, Steve.
Sorry, go ahead.
No, go ahead.
Well, we asked for, I think, what amounts to approximately a $90,000 increase. I would be happy to give you a detailed accounting of how that is expended and when it's expended in the year. But I assure you, and I'm not trying to sound defensive, but we are, I do question whether you wouldn't see the costs from the other partners in terms of what it costs them to pay their staff. And what it costs them to take care of their employees. Even if we paid for our own health insurance, we would have to build that in, and we would have to ask for year-over-year compensation increases for our staff. And I think every partner in this room would do the same, because they're all deeply committed to taking care of their employees. But again, I think this is a really good conversation to have, because I would want everyone to understand the impact that it would have on the system if you removed several $1 million of care from the community at a time where you're investing 2.8 in a crisis center, because we're where they come when they're out of the crisis center. And again, we have not turned anyone away. We don't even take people to collections. You might argue we're not very good business people at Burt Nash, but we're doing everything we can to hold it together without, and if it wasn't for the county, we would be in a drastically different position. But the best mental health centers receive a lot of county support. And I think there's a lot of opportunity if the county doesn't feel like it's getting what it needs from its mental health center to evaluate those partnerships and to see how we can leverage those investments that you're making there. But all of that sliding fee scale money are Douglas County citizens who are uninsured, who are getting a healthcare service. I mean, that's what every single one of those dollars is. And I think that's critically important for everyone to understand, and it's expensive.
So Stephen, I'm gonna give some grace to some of your comments there, because I think this commission and past commissions have been very supportive of mental health and
Yeah, I don't think Stephen's trying to indicate otherwise.
right. And so, but I do think I want to reinforce Sarah's point that it's about partnership and how those partnerships work, and how if we are funding, if we are a critical funder to one part of your services, and I would say in charitable care, we very much are, that we have that sort of discussion and it doesn't become, we changed our model and now we're putting on the county that you need to fund that change in model. I was hoping it was all COVID related, but I'm hearing it's not. So I think it's just having that continual conversation about how this partnership works. I wasn't making any claim that we would stop funding healthcare, that we would stop funding health benefits, I don't think I said any of that. I was just asking, as we think about our partnership, what are things that we're thinking about? Are we thinking about benefits? Are we thinking about salary package and those types of things? So I appreciate, the need, certainly. And I think we've shown that we are recognizing that need. We're an incredible county when you look across the state of Kansas about the type of support our community members provide. But that doesn't mean we can't get better at it and we can't be better partners.
And I think we recognize that there are structural issues that go well beyond this county. I mean, as Stephen, you mentioned, these are folks who are uninsured. We shouldn't have uninsured people in the United States. That's not something that we can control as a county. And so I think that this is something of how do we work with the situation that we're currently given and how do we do that in a collaborative way?
I did not mean to insinuate that I'm not really appreciative and thankful. It's been a really long 18 months, and those uninsured individuals place a tremendous amount of pressure on everyone in this room, and it's just really tough. So I was not in any way insinuating we're not thankful. I'm looking forward to the critical conversation, because again, I think when we all get under the hood, we can have some pretty deep discussions about these topics.
We have other questions for Burt Nash, or should we move on to the homeless proposal? I guess I'd ask Jill to maybe come to the podium. Matthew Falk has been moved into the panel, but just to kind of walk us through how this request has evolved over time and where we stand right now.
Commissioners, I'm going to let Matthew Falk cover the requests, but I just want to say I'm excited to see this request come forward. I think it is a result of the conversations and the engagement that we've had in the Built for Zero initiative. In particular, the request for the COC regional coordinator position. I've talked a few times about how important that role is. And my feelings around why that's important have largely been informed around the discussions that in the work that we've done in the Built for Zero initiative. If we want to, it's important that we underwrite and support the level of regional coordination that is necessary to connect folks to housing. I think Bert Nash has done a tremendous amount of work in allowing David Tucker to do that work. And I know Matthew has supported him in that work as well. But I think putting some resources to that regional coordinated effort, I think will be, it's something that we've learned through Built for Zero. I get a lot of questions of, where are you at with Built for Zero? Like, and this proposal is one of the most significant results of that work so far, in that if we want to have impact on our goal to get to functional zero with our chronic homeless population by 2023, we need to invest in more outreach. We need to invest in more coordination in the coordinated entry system. And so I think the proposal that Matthew has put together, and he's going to talk more about here, that they've made for the county and the city is a significant step forward. So I'm gonna let Matthew talk now.
Maybe real quick before Matthew jumps in, when originally we received this request, it was one request that went both to the city and the county. Now, what both the city and the county asked Bert Nash to go back and help us create some lanes inside the request so that we can better streamline accountability and responsibility for certain functions inside of that model. So what you see before you, some of the language talks about the whole request, but really what the county's being asked to support here is the coordinated entry piece and the other piece that I forget about all the time.
The qualified mental health professional
Yeah,
piece.
the QUIMP, and then the outreach worker positions are being asked of the city of Lawrence. Again, I'm not quite sure where they're at in their budget process in terms of funding that. But Jill talked about a little bit earlier today, she is completely underselling her work here on Built for Zero and the community based work that we're engaged with to try to build a comprehensive strategy around homelessness in this community, bringing all kinds of partners to the table, including our wonderful group of service providers as well as grassroots organizations to take all the pieces that we currently have that we're doing a lot of tremendous work with to identify gaps. We have the state of Kansas and KDADS at the table as a part of that presentation, and hopefully with funding, sustained funding for this work in our community, which has really been the missing piece to a lot of these puzzle pieces. City of Lawrence is key to this work because, as Jill mentioned before, they hold community development block grant and emergency shelter grant funds. Those are the primary federal funding sources for this work. So City of Lawrence is a key part of this component piece as we go. This group is now meeting weekly to continue to try to develop this plan and prepare for a KDADS proposal later this summer. They will be working closely with Bob Tryansky's team in terms of supportive housing and developing what those supportive housing models are and those assessments so that we can inform our, hopefully, ARPA plan and to help place some resources in that area. So I just want to provide a little context to that piece.
Can you talk a little bit more about KDAD? You mentioned it. That's what I was
Yeah.
waiting for, is like, how does this all fit in with the KDAD's proposal?
Well, there's going to be a lot. The KDAD's proposals, we understand it right now, is $500,000 of one-time funding that's based on Housing First, which Built for Zero is a Housing First model. Jill's going to tell me if I say anything wrong, but it's a one-time $500,000 proposal. So Bob and Jill and Brandon McGuire at the city have been working to try to challenge our partners to help us put together a proposal for that within the next week to submit to the state in terms of funding for that pilot. I do think KDADS has talked about additional funding. I've not seen anything in writing, so I'm just reluctant to speak more about what they've discussed until we see an actual proposal in terms of that. But that doesn't diminish the work that the KHRC, which I'm going to forget what that acronym stands for, the Kansas Housing Resource Corporation, has invested significant funds in this community in the last year or so, as well as ESG dollars too as well. So the problem here is there's lots of funding sources. But there's lots of issues and there's lots of different angles on how we approach homelessness in this community. So this is a key piece that I think we feel like we need to sustain here at the local level in terms of support for this work that frankly, everybody's been doing for the last 3 to 4 years on top of everything else they already have. This has fallen to an overburdened homeless outreach team to try to manage a pretty difficult database and a difficult clientele to track. And so we felt like it was important to make that investment in the team. And I'm hopeful the city does as well in terms of outreach.
I consider this infrastructure, basic infrastructure of a high functioning housing prevention, coordinated entry. Like these are the basics. This is what Built for Zero starts with. Like you need a database. You need a by name list. Well, that's your HMIS system. We've not had a good one historically. And then you need a system to connect folks to housing. That's coordinated entry. We haven't done that great as a community either. We're making strides towards that, but I consider this proposal being reflective and the one that's been made of the city basic infrastructure that we need to connect folks to housing and prevent homelessness. So I'll let Matthew talk a little bit more though.
Well, I do just want to, I love the framing of this is basic infrastructure, and I think that you're 100% correct. I'm very disappointed that we're not going to see some federal legislation around basic human infrastructure for quite a while, and that's another disappointment in a space where I think we may potentially see funds if our community is ready for it. My concern is that this is basic infrastructure that we need to build in our community. It's how are we doing the coordination to build it? Because I think the point that Sarah made of Bert Nash presented a proposal that was the same proposal to the county in the city. We then had to go back and ask and say, what's the county lane? What's the city lane? I think as we think about this overall building of the infrastructure, who's responsible for maintaining it and thinking strategically overall about what that looks like for our community. And I think that strategic leadership and maintenance are pieces of infrastructure that we constantly have to consider. And this, since we're just building it, it's a harder one for us to know what that looks like long-term.
Yeah, but I think we've made progress. I think we will continue to do so. And I think that's the real value of a plan, of the plan that's going to be put together, is it will give us those kind of guiding lanes but yet not diminish the importance of collaboration here, because it cannot be done by any one organization in this community alone. It simply can't. So but we all need to feel comfortable in the space and making sure that it is. And I feel like the way this proposal is structured and our conversations with the state's, balance of care and some of those different groups, that we have a pretty good feel at the county level that this is in the right spot. But I definitely hear your concerns. So, and before I turn it over to Matthew, I will mention we've got about 5 minutes to wrap everything up and in this today. So I don't know if there's any particular questions we have for Matthew on this proposal that we want him to speak to.
This is Commissioner Reed here. I do have a specific question about the COC coordinator. And well, I guess first my comment is that when I read that and the qualified mental health professional, the qualified mental health professional position associated with the homeless outreach team, the work that's already been done and can be built upon, those things make sense to me to live at Bert Nash. But the COC coordinator doesn't quite strike the same feeling for me. And so I'm curious to understand what the thought behind having COC regional coordinator be based at Bert Nash out of all of the agencies in our community that work on homelessness issues that are part of coordinated entry. And I guess I'm wondering what the model looks like in other regions of the state. The Kansas COC is housed, I suppose, or kind of managed, maybe, I'm not sure what the best word is for that, through the Kansas Housing Resource Corporation Coalition. I can't remember exactly what the C is there, but so I don't know if Matthew or if Jill is best to speak to what those regional coordinator, do other regional coordinator positions for COCs live inside KHRC, or do they tend to be embedded in one agency out of many agencies that all work together through coordinated entry? In our situation, Built for Zero, those teams overlap. So can one of you help me understand that?
Yeah. So the regional coordinator position historically here and within other regions of the state is a voluntary position. So it's really been a process of willy-nilly who has stepped up to fill that position. Before we were filling that position, it was an employee of the Housing Authority who was the manager of their permanent supportive housing program at the Hope House. And it has gone through a few iterations. So that being said, I think the struggle here is that you have the Department of HUD who has provided guidelines and requirements around how they want communities to operate and coordinate services and expectations on the kind of work they need to be performing. But that has been left totally up to the regions to create that on their own, to sustain it on their own. And in pretty much every step of the way, that's people voluntarily stepping up to do it above and beyond the duties of their existing jobs. The COC is the same in the sense of the changes that have happened thus far. So the COC traditionally was aligned with the Kansas State Homeless Coalition. They have separated their governing structures. The COC has its own governing board, and they contract with the Homeless Coalition to provide some administrative duties for them, and those are paid positions. But the boards, I sit on a few of those boards that they're voluntary positions as well. So one of the challenges is how do you manage the workload? Because the workload that's associated with the COC process and managing that locally becomes extremely heavy. And as we have ramped up our coordinated entry system, as we have really made extensive efforts to get ourselves into the best to get that system operating as best as it possibly can. And I would like to say that we are probably doing better than anyone else in the state with our coordinated entry system. We have a lot of work to do. We have a lot of progress to make. But we are a model for the rest of the states to use and show how that can work when it's starting to work really well. And in all honesty, the reason the reason that has happened is because a few people, including myself, stepped into the fray when the system was kind of not doing so well, when the person with Housing Authority had to leave their job and fell apart, and we made it work and we brought it all back together. In some sense, that's why it sits with us, because we volunteered to do it and we've been providing those efforts on our own. And another, I guess, way of looking at it, we, over the years with homeless outreach and in our coordination with all the other providers, we were in a prime position to coordinate all of that. We had established the natural relationships with the agencies. We had established the connections to call them back to the table. And, that's kind of, in some sense, how it also came to play out, is that we were in a better position, to provide that service at the time. That being said, the level of work that is required to provide the coordinated entry or the regional coordinator, role is a full-time job. And especially when you consider what we're doing with Built for Zero and the level of work that has been associated with that is a full-time job. And it definitely deserves, it needs to be supported as its own function within our system. I think that's a good conversation to have. Where does that need to happen? Where does that need to lie? Where does that position need to be? I guess my 2 cents on it is that we've already created this infrastructure. We're already in a place in which we're starting to operate really well. So I guess if it ain't broke, don't fix it, in that sense. On the other hand, if you're going to look at an agency on where to house that, I guess my 2 cents would be, the regional coordinating team, the coordinated entry team should be definitely included in that conversation, and they should be the ones who consult to make that decision. also vote who's the regional representative, and that's a COC process. The regional coordinated entry group is supposed to vote on who that representative is, and that representative is not necessarily does not have to be the same as the regional coordinator. Those are kind of in some sense two different roles, but the impetus for creating this proposal and these proposals, initially we were just asked to field the proposal, one single proposal, and to familiarize the notion and the concept with the city and the county. We were asked to do that, which is why the initial proposal was a single proposal and not split up. And out of that conversation, we engaged in the wider conversation of whose lane is what and who should be responsible as the county and the city work together to define more clearly what your role is and your partnerships in relation to this specific issue. The impetus of this is need. As you know, as you walk around the community, you drive around the community, there's a high level of need in the community. And we do not have adequate services or housing in place to explicitly address the need. We're kind of digging ourselves out of a hole, not only as a region, but as a nation. And as Jill said, these are infrastructure issues that we need to have in place in order to start really digging ourselves out of that hole. So for the operation of my teams, right now, the COC position and the team leadership position of the outreach team is being fulfilled by one person. And it is extremely difficult to balance that in a successful way. So I need to split those up personally, operationally. I need a dedicated team leader. And they need to be a queue. They need to be able to provide clinical services. And we, as a region, we need a dedicated regional coordinator that can devote 100% of their time to the duties of that position. So that's the logic and reason behind this. Again, I definitely think we can have a wider conversation of where that needs to be housed. But I would support that being housed at the coordinated entry team, and that conversation be kind of started there because they're the ones who are really running that program, and they're the ones who really will really be working with that individual and coordinating with the whole process. That being said, that regional coordinator is a coordinator, right? They kind of are the chair of the committee, and their job is to kind of get everybody at the table and get them all doing the work. Their job is not to do all that work in the sense of serving the clients. Their job is to coordinate the coordinated entry process. The second portion of this proposal, which is with the city, which is to fund the outreach workers. Again, as Jill said, that's going to be tight. We're waiting on the city to move through their budgetary process and see what happens there. We're waiting to hear back on Rescue Act dollars and to receive firm guidelines on how and when and where that money can be spent. So that's a big piece of this puzzle, but we have to do this. We have to do something, right? If we want to make any kind of headway, this is a necessary piece of the puzzle in outreaching to other people. I do think that this also should be discussed in the wider context of the process we're going through with the comprehensive housing and homeless plan, the housing first proposal that we're fielding with the state, and the services that are associated with that proposal. I think there's a lot of opportunity to discuss how these systems work together, where they overlap, how can we align them and leverage them in a lot of ways. So for example, there's an ACT team associated with the Housing First proposal. I think that makes a lot of sense to really look at the homeless outreach team and that ACT team and see where there's some overlap and see where we might be able to achieve some efficiencies by closely aligning those teams together, and achieve some efficiencies by aligning this proposal with that other proposal. Both efficiencies in just overhead, like office space, where do we house them? How do we pay for that? Efficiencies in how they operate together, et cetera, et cetera. But I went far afield from your initial question, Commissioner Reed, but I hope that helps.
Do we have any other questions for Matthew?
I have a question of Heartland Community Health. I just want to make sure we save enough time for that. So I see that they're here.
Okay, I think we're done with this one. Pat, Commissioner Kelly, what was?
I see we have some representatives of Heartland Community Health. Could you guys come up to the mic? I just have some quick questions for you. I don't know that this should take long, but I have been getting quite a number of communications from people in the community about Heartland. I think we've seen 2 executive directors leave, and I understand that you have another staff member who's been fired. That's a pattern in other organizations that the county funds. I'm thinking specifically of the Lawrence Community Shelter. When we saw some disruption there, as a community partner, we participated. We had some work that we did with them. Jill serves as an ex officio on that board. I just want to give you a chance to comment on all the disruption and the sort of pattern. And when I've reached out to your board members, I'm getting nothing in response. I know Sarah has talked to your executive director, but as we think about your budget request and we think about your supplemental request, I just want to give you a chance to respond to all that.
Well, we thank you, and I'm going to invite Julie Bodine-Schmidt. She's our current interim CEO to speak on these types of matters.
I guess it's good afternoon now. I'm Julie Bodine-Schmidt. I'm the interim CEO. I was the interim CEO also 2 years ago. So I'm back. I think that when I left 2 years ago, the organization was in a good position. It was just starting to grow. There were discussions already with Douglas Daniel. Unfortunately, I think you don't always know who you're getting when you make an offer. And I once had a medical director say, I think we could have just as good luck tossing all the resumes down the stairs and the one at the bottom gets a job. So there certainly were problems with the last CEO, and she was finally asked to leave by the board. I'm sure you can appreciate that. One, I'm not privy to a lot of information, and 2, I couldn't share it. I think another part was we've undergone 2 mergers. One was with Douglas Daniel. That was relatively seamless. When I was here 2 years ago, I'd already started discussions with Julie Brandstrom. It was a wonderful addition. The second, which was actually an acquisition, came January 1, and that was with Panda Pediatrics. That has not been as smooth, and I'm sure you can appreciate when you take a federally qualified health center that is mission-driven, not-for-profit, and you combine it with a for-profit physician-controlled practice, there are going to be some bumps, and there have been. But I'm really pleased to say that I think the boulders that I encountered when I was here have now become fairly large rocks, and I see our way to having a relatively smooth. Health centers will always have a bunch of pebbles in their way. We are trying to address some of the issues that have come up over recent events, including the issue of equity and diversity. I am having people serve advisory to me. Somebody previously mentioned, I'm a white woman in privileged shoes, but we do have people on our staff, people on our board, and people in our community who can help me walk through how do we improve diversity on our staff, how do we improve it on the board, and how do we reach out better to that diverse community in Lawrence. So I think we continue to make progress. We continue to provide great care. Panda was listed first in pediatric practices. Our chief medical officer is the 3rd in physicians, and Heartland in the top 10. So we continue to provide quality of care. I think we have an incredible team that is now working to not just stabilize, but really grow and flourish. And, in the meantime, we will deal with each issue as it comes up.
Thank you.
Thanks.
Commissioners, I think we're at the end of our planned time for today. I know we had Artists Helping the Homeless here if there were questions for their proposal. Bob kind of covered it, so unless there's specific questions, I think it would be good to come back tomorrow and just, we can get you some updated information, make sure everybody has the pieces that they need, talk a little bit about logistics as we move into deliberations after the holiday. So if that's it, I think we're done for the day.
Thank you.